Vanakkam. Arthrogryposis seems to be a very commonly used term when we come across flexion contractures in the hand. But arthrogryposis is much bigger. It encompasses a lot of conditions, of which one is flexion contracture in the fingers. In this video, we shall see all about arthrogryposis and conditions that are associated with this diagnosis, like for instance camptodactyly and congenital clasp thumb. The term Arthrogryposis Multiplex Congenita appears to be a very complicated word, but it has a very simple meaning. Arthro refers to involvement of the joint. Gryposis refers to hooking or hook-like curvature that occurs at the joints. Multiplex implies multiple joint involvement. To illustrate this, let us consider these two babies. This child has involvement of both feet with bilateral club feet and involvement of both upper limbs. This would come under the classification of arthrogryposis, whereas this child who has a club foot but all the other limbs are normal would be classified as club foot only. Congenita of course refers to congenital or present at birth. So the symptom complex of Arthrogryposis multiplex congenita can be applied to any child with congenital joint contractures in two or more limbs as seen in this clinical example. You can see the wasting of the muscles and contractures in both shoulder joints and in both hands. Over 300 types of arthrogryposis have been identified. So it is difficult to make a very specific classification. But basically arthrogryposis may fall under one of three headings: amyoplasia, distal arthrogryposis, or syndromic arthrogryposis. Amyoplasia refers to idiopathic non-genetic disorder with a wide range of severity and anatomic involvement, and we shall see more about this later in this video. Distal arthrogryposis refers to genetic disorders which have about 11 discrete patterns, each with variable penetrance, and this involves mostly the distal parts of the limbs. And the syndromic type refers to multiple congenital joint contractures occurring due to primary neurological or muscle causes. The occurrence of Arthrogryposis multiplex congenita is about 1 in 3000 live births. It is seen to affect both males and females equally. This picture shows a sister and brother, both of them having arthrogryposis. The condition appears to be common in Asian, African and European populations. The prognosis of this condition depends on the underlying cause and the extent of the contractures. It is to be noted that 1/3 of infants born with Arthrogryposis multiplex congenita are either stillborn or die before their first birthday. The exact etiology why arthrogryposis occurs in multiple joints is still unknown, but several theories exist and they can be classified as extrinsic and intrinsic theories or causes. Extrinsic causes of arthrogryposis include decreased movement of the fetus in utero. It is proposed that this decreased movement in utero allows excessive connective tissue to form around the joints, that is, fibrous ankylosis. The causes of this decreased movement in utero could be fetal crowding, maternal disorders like Zika viral infections, drug use, trauma, and oligohydramnios. As far as intrinsic causes are concerned, it could be genetic and environmental factors playing a role, or chromosomal disorders like trisomy 18, otherwise known as Edwards syndrome, or sometimes even single gene defects which could be X-linked recessive, autosomal recessive, or autosomal dominant. Connective tissue disorders. These are believed to cause arthrogryposis by causing a loss of muscle mass with an imbalance of muscle power at the joint, which can lead to connective tissue abnormality. resulting ultimately in joint fixation and reduced fetal movement. Arthrogryposis can also be associated with specific muscle conditions including muscle dystrophy like myopathy and mitochondrial disorders. Arthrogryposis presents with involvement of all the limbs in 84% of the patients, involvement of only the legs in 11%, and involvement of only the arms in 4% according to a study. But we must note that this condition affects the entire musculoskeletal system. As far as the muscles are concerned, absent or hypertrophic muscles are seen, but associated tendons and the overlying fascia usually remains intact. As a result of this, as the child grows, these non-contractile tissues, that is the tendons and fascia, can tether the joints, leading to joint contractures. The bones are usually osteopenic, the cortices are thick, but the bones are small in diameter, with the medullary canal being almost nearly absent. The motor and mixed nerves are also seen to be smaller in caliber. Even the subcutaneous fat, which forms a very large percentage of the bulk of arms in children, is very much diminished. Now let us see the specific clinical features of arthrogryposis multiplex congenita. But the features depend on whether it is a generalized involvement, as in amyoplasia, or only restricted to the hands and feet, as in distal arthrogryposis. The syndromic forms can be considered under these headings itself. Amyoplasia simply means non-development of certain groups of muscles. They are associated with many features, like for instance, the child will have high cheeks, button noses and stork bite hemangiomas over the occiput and the bridge of the nose. These hemangiomas are usually flat and small. They are benign and most of them resolve or diminish over time. It is only if the lesions are raised that they should be imaged to evaluate for intracranial extension. These children usually show average to above average intelligence. Though association with other medical conditions are rare, in syndromic conditions there may be respiratory involvement needing mechanical ventilation or gastrointestinal involvement with evidence of bowel atresia and abdominal wall defects. The skin of these children is usually waxy, devoid of skin creases. There is considerable muscle wasting and, as we have seen, paucity of subcutaneous tissues. In the lower limbs, the hips may be dislocated, the knees are usually kept in extended position, and the feet may show severe equinovarus contractures. As opposed to amyoplasia, distal arthrogryposis can be classified into 11 discrete types. Distal arthrogryposis type 1 is the typical or commonly occurring condition that we see. It is characterized by the occurrence of camptodactyly, clasped thumb and clubfoot. In distal arthrogryposis type 2A, which is seen in the Freeman-Sheldon syndrome, there is a combination of whistling face deformity, camptodactyly, clasped thumb and clubfoot, and in type 2B, which is called the Sheldon-Hall syndrome, prominent nasolabial folds, down-slanting palpebral fissures, small mouth, along with camptodactyly, clasped thumb and clubfoot are seen. In type 3, which is sometimes known as Gordon syndrome, short stature and cleft palate are seen along with camptodactyly and clubfoot. In type 4, scoliosis is a prominent feature along with the other features of arthrogryposis. Distal arthrogryposis type 5 is characterized by ophthalmoplegia and ptosis, and the camptodactyly, as you can see in this clinical picture, and in type 6 the deformities involving the lower limbs are associated with sensorineural hearing loss. In type 7, trismus and pseudo-camptodactyly are present, whereas type 8 is otherwise known as Escobar syndrome, which is characterized by multiple pterygiums, that is webbing that is seen typically in the elbows and the knees. In type 9, otherwise known as Beal syndrome, camptodactyly, arachnodactyly are seen along with kinked upper ear and tall stature. In type 10, congenital plantar contractures may be seen along with the other features like camptodactyly. When clinically examining a patient with arthrogryposis, we need to assess every joint on both arms, recording the active and passive movement as well as the joint's resting position. Every single joint on the upper limb has got a characteristic pattern of involvement, and we shall learn about the involvement of each joint in the upper limb. The shoulder typically is in a position of internal rotation, the elbow is in a position of extension, forearm in pronation, wrist in volar and ulnar deviation, hand with fingers in flexion, and thumb in palm, otherwise known as the clasped thumb. As far as the shoulder is concerned, internal rotation and adduction contractures of the shoulder are common. The shoulder often has limited motion secondary to undeveloped musculature, capsular contracture and joint congruency resulting in internal rotation deformity. The shoulder rotation should be assessed by flexing the elbow to 90 degrees, placing the arm in adduction and then doing passive external rotation of the shoulder to assess the degrees of passive internal and external rotation. Finding the axis of rotation of the shoulder in a child with less than 30 degrees of passive elbow flexion becomes difficult. Children with more than 90 degrees of active abduction and active external rotation past neutral rarely require any intervention as far as the shoulder is concerned. But in this child with amyoplasia, there is only about 60 degrees of abduction at the shoulder on the left side and 10 degrees of abduction of the shoulder on the right side. The elbow can present with either flexion or extension contractures. The commonly seen pattern is if the triceps is preserved and the elbow flexors are deficient. This will result in an elbow extension contracture as can be seen in the right elbow of this patient, or if the triceps is weak or absent with an active biceps, elbow flexion contracture may result as seen in the left elbow of this patient. If both triceps and elbow flexors are absent, the elbow may be fixed in a straight position, or there may be a minimally mobile elbow joint that positions around 60 degrees of flexion. Classically, the forearm is usually described in arthrogryposis as fixed in pronation in the majority of children. However, most forearms are usually positioned in neutral or slight supination. It looks like a pronation contracture because of the internal rotation contracture of the shoulder combined with an extended elbow. The involvement of the wrist differs in distal arthrogryposis and in amyoplasia. In distal arthrogryposis, the wrist is most often in extension or in neutral position as seen in this clinical example, whereas in amyoplasia, the wrist is in a fixed flexion contracture. You will note in this patient that the metacarpophalangeal joints are in hyperextension. That is because the child tends to compensate for lack of extension of the wrist by using the intact finger extensors. When we come to the involvement of the hand function and fingers in arthrogryposis, there is a highly variable presentation, but it can be generally classified as one of four types: wind-blown fingers, claw fingers, camptodactyly, or stiff straight fingers. Wind-blown fingers is characterized by ulnar deviation of fingers at the metacarpophalangeal joints, and this is usually seen in distal arthrogryposis conditions. Claw fingers are characterized by absent intrinsics and wrist extensors. So because the extrinsic finger extensors are preserved, there is a hyperextension at the metacarpophalangeal joint, and we have just seen an example. This type of presentation of claw fingers is characteristic in amyoplasia type of arthrogryposis. The third type of finger involvement, that is known as camptodactyly, is characterized by contracted flexor digitorum superficialis, weak or absent extensor mechanism, and it can be seen in amyoplasia or distal arthrogryposis. Stiff straight fingers are characteristic in amyoplasia where there is an absence of finger flexors and extensors. So all the joints of the finger are fixed in neutral position. Since there has been no movement, the finger flexor creases are also absent, as can be seen in this clinical example. When examining the hand in arthrogryposis, we need to do three important things. We need to record the active and passive motion of the PIP joints of the fingers. We need to do a central slip tenodesis test, and we also need to assess the function of the flexor digitorum superficialis and flexor digitorum profundus. The first step of recording the active and passive motion at the PIP joint is very important because it helps to differentiate a flexible deformity from a fixed flexion contracture. A fixed PIP joint flexion contracture implies shortening and thickening of the flexor tendon sheath, check rein ligaments, volar plate, or any combination of these structures. The amount of passive PIP joint extension is determined while varying the positions of the wrist and metacarpophalangeal joint. Flexion of the wrist and metacarpophalangeal joint can often increase the amount of passive PIP joint extension. So this would imply tightness of the extrinsic flexors, mainly the flexor digitorum superficialis. The next important clinical maneuver to be done during examination of the hand in arthrogryposis is the central slip tenodesis test. The passive component of this test is done by putting both the wrist and metacarpophalangeal joints in flexion. When this is done, the PIP joints should automatically extend. If it does not do so, it indicates that the central slip is attenuated and must be corrected first. The active component of this test consists of putting the metacarpophalangeal joints in flexion and asking the patient to extend the proximal interphalangeal joint. This will again indicate the intactness of the central slip. This test is very similar to the Bouvier test that we do in ulnar nerve palsy. The third important test in the hand is to assess the flexor digitorum superficialis and the flexor digitorum profundus individually for each finger. Involvement of the thumb is characteristic in arthrogryposis, but there are two patterns that can be seen: the stiff straight thumb and what is known as the clasped thumb. When there is an absence of thumb flexors and extensors, as seen in amyoplasia, the thumb becomes stiff and straight, as seen in this clinical example. Clasped thumb can be seen in all types, that is amyoplasia and distal arthrogryposis. It is characterized by contracted flexor pollicis longus, thenars, adductors, first dorsal interosseous, and weak or absent extensors. Under the classification proposed by Maccarel of clasped thumb, there are three types. In type 1, there is a flexion at the metacarpophalangeal joint, and this is due to the absence of the extensor pollicis brevis muscle. Normal motion is seen at the interphalangeal and carpometacarpal joints. In type 2, there is no full passive range of movement at the interphalangeal joint or metacarpophalangeal joint, and in addition, there is a flexion contracture at the metacarpophalangeal joint of the thumb associated with skin deficiency and joint abnormalities. As a result, concurrent passive extension of the metacarpophalangeal joint and abduction of the carpometacarpal joint is limited by soft tissue deficiencies. But the passive interphalangeal joint extension and active interphalangeal joint flexion are preserved. Type 3 clasped thumb is typically seen in severe arthrogryposis or amyoplasia. There is no passive motion at the carpometacarpal joint, metacarpophalangeal joint, or the interphalangeal joints. It also demonstrates true thenar and adductor deficiency along with extrinsic flexor tightness. This child with amyoplasia shows bilateral type 3 clasped thumb. It is important to note that the skin deficiency or soft tissue deficiency that is present in the clasped thumb is present in the thumb index finger space, which is obvious on attempting radial abduction, and also deficiency in the thumb palm space as seen by a persistent palmar abduction. Clinical examination forms the cornerstone of diagnosis in arthrogryposis. However, some investigations will be required in certain situations. Routine radiographs are unnecessary for patients with arthrogryposis except in children who have got severe flexion contractures or camptodactyly, where X-rays may show the dislocation of the proximal interphalangeal joints. Neither CT nor MRI is necessary for the diagnosis. However, evaluation of donor muscles for transfers like pectoralis major, latissimus dorsi or gracilis is difficult to quantify via clinical examination and may require an MRI or CT scan. This axial MRI on the left leg of a child with minimal clinical lower extremity involvement demonstrates diffuse muscle atrophy and fatty replacement with near complete absence of the muscle within the gracilis facial compartment. Electrodiagnostic studies are rarely necessary other than in evaluating alternative neurogenic contracture syndromes like spinal muscular atrophy. Muscle biopsy does not yield useful information unless an alternative diagnosis like muscle dystrophy is being considered. Ultrasound may be useful to diagnose the lack of fetal mobility and abnormal position in the womb during the prenatal period. Comparative genomic hybridization array is used to identify segmental DNA copy number changes. Exome studies can be done, and particularly whole exome sequencing, that is WES, involving analyzing the protein coding regions of a genome to identify genetic variations that may be associated with diseases or traits, can be done. So, Arthrogryposis multiplex congenita encompasses varied presentations at various joints involving the entire upper limb. Some deformities obviously show poor function of the limb. Is it possible to get back function? What procedures do we need to do, and how do we make a decision? All this will be dealt with in the next video chapter on management of Arthrogryposis multiplex congenita. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about other congenital problems like congenital syndactyly and the surgical management. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics.